Good morning, ladies and gentlemen. This is a very big day for myself and my channel that I am recording the 200th lecture in my channel. You all know this is just a pure academic session, academic channel with no financial interest. So if I am able to teach you well, this is my reward. And I'm really thankful to all of you who have taken my lectures and wrote me and encouraged me. So the topic of today's lecture is the acquired disorders of pilosebaceous units. I am Professor Asher Ahmed Mashood, and I am Professor of Dermatology and Aesthetics. You can follow me on my Instagram, and you can message me on email and WhatsApp. The first disease we are going to discuss today is the pseudofolliculitis. The pseudofolliculitis is an inflammatory follicular and perifollicular foreign body reaction to the hair which are trapped beneath the skin surface due to retraction of the cut ends of the hair into the skin following shaving or as a result of disturbed hair growth following plucking or waxing. So this problem is seen commonly among those people who tend to shave their hairs very close. And in doing that, they move the razors in various directions, as a result of which the cut ends of the hair, they turn back into the skin. And it is also very common among those who have wrinkly hairs as compared to straight hairs. Areas particularly affected are those most frequently shaved, which include the beard area, the pubic area, and the lower legs. Pseudofolliculitis of the beard area is very common, and reportedly it is seen in 80% of African males. And it is mostly seen after puberty, of course, when the hair becomes thick. And men of African descent are more predisposed, primarily because of the thick hair they have and the curly hairs. Pseudofolliculitis is also reported as an adverse drug reaction to minoxidil, which is the drug that stimulates the hair growth. Pathology. Penetration of the aberrantly cut hairs into the follicles or surrounding tissue results in acute inflammatory reaction surrounding the hair with microabscess formation and foreign body giant cell granuloma formation. Coagulase negative staph or staphylococcus may sometimes be grown from the lesion, but the condition is primarily not an infection, but rather a foreign body inflammatory reaction. So it is actually not an infection. It is the foreign body reaction which is created by the presence of cut hairs into the skin as a result of the causes I've already mentioned before. The clinical features. The condition typically manifests as multiple small papules or pustules on the shaven skin, particularly the beard area. Skin of neck and over the jaw is most commonly affected, although cheek may also be involved. These are the neck and jaw areas are those areas where the shaving is a little difficult. That is why the shavers use the blade in various directions for close shaving. Papules may be larger in size and scars may form and even keloids may develop later on and post-inflammatory hyperpigmentation. It is generally possible to identify some penetrating hairs, ingrown hairs, but they are not always visible. The clinical appearance may lead to significant distress because it's a chronic condition with papules on the face. It does not look nice. Diagnosis is usually obvious, but in case if there is any doubt, then history of shaving, plucking, or waxing would help clinch the diagnosis. This is how the pseudofolliculitis would look like. If you look closely, you will be able to appreciate the cut hairs which are present in the various directions according to the direction of razor which was used. The differential diagnoses include bacterial folliculitis, psychosis barbae, and dermatophytosis. Bacterial folliculitis is an acute infection. Psychosis barbae is a chronic lesion with scarring, and dermatophytosis is also acute on chronic. So the complications and comorbidity. Pseudofolliculitis, particularly of the beard area, result in hypertrophic and keloidal scarring. Disease course and prognosis. Pseudofolliculitis, as mentioned, is a chronic condition with relapsing and remitting course. Avoiding shave can allow the skin to recover. Otherwise, intermittent treatment may be required. Another option is permanent hair removal at the high-risk site in selected cases. Management. The only certain cure is stop shaving and for a maximum 4 to 6 weeks. That would allow the inflammation to settle and allow the hairs which have grown into the skin to grow out of the skin, and so that no ingrowth occur. Then shaving in one direction is useful. Resumption of shaving or waxing often lead to relapse. So rather than shaving daily, which is of course not possible in military life or in few other services, shaving 2 to 3 times per week will be more beneficial in such patients. Lifting out of the re-entrant hair with abrasive sponge or toothbrush to release the hair is less effective but a quicker remedy. Some relief is possible by the topical use of antibiotic-steroid combination and emollients. Then hair removal with chemical depilators, topical eflornithine, or combination of eflornithine and hair removing lasers are the ultimate choices of treatment. So the treatment ladder would be like that in the first line, stop shaving the area for 6 weeks and apply topical steroid antimicrobial cream. The second line treatment will be to restrict shaving to 2 to 3 times a week rather than daily, and chemical depilators rather than physical hair removal. And third line is the permanent hair removal of the affected area. The second condition we are going to discuss now is the folliculitis keloidalis. Folliculitis keloidalis is commonly known as acne keloidalis, is a common inflammatory process that involves the hair follicles of particularly the nape of the neck, which leads to hypertrophic scarring. In order to avoid confusion with keloid formation in association with acne vulgaris, the term folliculitis keloidalis is preferred to acne keloidalis, because by the term acne keloidalis, it means that the keloid formation is following the acne. The folliculitis keloidalis is a disease of male, of course, after puberty, and the most frequent age is 14 to 25 years. And it is again seen commonly among the African descent. Predisposing factors. There is no specific organism involved, but still Staph aureus is the most commonly isolated organism. The predisposing factors are wearing a hard collar, and the friction of the collar with the hair at the nape of the skin is considered to be the most important incriminating cause, although the evidence is weak. There is also an association between frequent haircuts, that is, less than 2-week interval, with a razor used at the neck. This is common in boys in cadet colleges and young soldiers. This finding and observation of foreign body granuloma surrounding the fragment of hair has suggested that the process begins with penetration of cut hairs into the skin, as we see in pseudofolliculitis. Associated keloids in other sites seem not to have been reported, and the process is regarded as hypertrophic scarring rather than keloid. So despite of the name, which contain keloidalis, this is more of a scarring rather than keloid formation. And those persons who are suffering from this condition, it is not necessary that they should have keloids at other body areas. So you can see on histopathology the destroyed hair follicles, acute on chronic dense inflammatory reactions surrounding the follicles, disappearance of sebaceous glands, and there is strong foreign body giant cell reaction, and you can see the thick collagen bundles which shows scarring. The clinical picture is seen here. It's characterized by follicular papule or pustules, irregularly grouped, maybe linear, at the nape of the neck just below the hairline, and it may extend into the occipital region, into the hair. The patient becomes aware of this condition when hard keloidal papules develop at site of follicular inflammation. Papules may remain discrete or fuse into horizontal band. You can see the horizontal bands in the picture, or irregular plaques. The condition is extremely common, and new lesions continue to form at regular intervals. Disease course and prognosis. The condition is usually chronic with permanent keloidal scarring. Investigation, nothing is required except skin swabs if bacterial infection is suspected. Management. If bacterial infection is present, then it should be treated with an antibiotic and antiseptics. The best advice is to avoid the close shaving or use of razor by the barbers at the nape of the neck. Once these scarring lesions develop, then we can use intralesional potent topical corticosteroids or cryotherapy to reduce the scarring. If keloids are big, the affected area may be excised and grafted, or excision is done with secondary intention, or if the keloids or scar are small, then it can be closed by primary closure. Laser-assisted hair removal with long pulse and DIAG causes miniaturization of hair shaft, which is thought to reduce the subsequent inflammatory process. So the next disease we are going to discuss is the necrotizing lymphocytic folliculitis of the scalp margin. This is an uncommon condition which is characterized by necrotizing folliculitis that appear in crops, primarily along the frontal hairline, resulting in multiple small, round, varioliform scars. And this condition responds to anti-acne treatment. Previously, this disease was named as acne necrotica varioliformis, but now the name is rephrased as necrotizing lymphocytic folliculitis. Aggravation in summer is reported. Early lesion is a dyskeratotic follicular lesion. As the lesion progresses, more widespread necrosis is seen, involving the follicular epithelium, the surrounding epidermis and dermis, and often contain fragments of hair. There is a prominent lymphocytic perifollicular inflammation, infiltrate. Staph aureus can sometimes be cultured. The disease onset is insidious, and appearance of papules are seen first in the frontal hairline, and more rarely in other seborrheic areas of the skin. Some patients experience mild pruritus. These papules gradually umbilicate, develop first central areas of necrosis, followed by crusting over the course of weeks. And ultimately, as they heal, they leave depressed varioliform scars. So this is how the acne necrotica varioliformis or necrotizing lymphocytic perifolliculitis manifests. Differential diagnoses are long that include papillonecrotic tuberculite, tertiary syphilis, repetitive excoriations, folliculitis decalvans, eczema herpeticum, pyogenic bacterial folliculitis molluscum contagiosum. And one more differential, that is the scalp folliculitis, in which the lesions are typically distributed throughout the scalp and not just the frontal hairline. And they are numerous and they are non-scarring. Otherwise, the acne necrotica varioliformis will leave varioliform scarring. So treatment ladder is, if Staph aureus is fine, we treat it with anti-staphylococcal therapy. If it is not found, then tetracyclines are given in acne doses for a long period of time. Antibacterial shampoos are also recommended. Second-line treatment include the anti-inflammatory treatment with topical or intralesional corticosteroids. And if nothing helps, then isotretinoin, oral. The third condition we are going to discuss today is the scalp folliculitis. It is a very common condition, and we see frequently young boys presenting with this problem. It's a non-scarring, chronic folliculitis of the scalp, and it's characterized by multiple minute itchy pustules distributed throughout the scalp and is attributed to a reaction to the presence of microorganisms, particularly Propionibacterium acne. Because of itch, secondary excoriations also seen, and crusting is common. Histologically, in contrast to the acne necrotica varioliformis, there is neutrophilic folliculitis without necrosis. In other condition, it is the lymphocytic folliculitis with necrosis. So scalp folliculitis, the difference is it is first the infection of Propionibacterium acne, and there is lots of itching, and it's a neutrophilic folliculitis and no necrosis. Onset is in third and fourth decade. Male to female ratio is high, 3:1. You can see these small itchy papules evenly distributed in the scalp. Treat this condition like acne. So you can give azithromycin for a long period of time, minocycline or tetracycline. The low-dose tetracycline and topical clindamycin lotion appear to be of benefit, but topical corticosteroids do not help. There is a little information as whether topical preparations like tar shampoo may be beneficial. But even if you are not prescribing tar shampoo, you can prescribe any other anti-dandruff shampoo. And another advice which you must give to your patient is to avoid oiling the scalp, because oiling would make the condition worse. So the next condition we are going to discuss is actinic folliculitis. It's a unique condition in which you can see follicular lesions in the photoexposed areas, and it is a photodermatosis of an unknown etiology. And it is characterized by numerous pruritic monomorphic follicular papules and pustules that appear in photoexposed sites several hours after the sun exposure. This condition normally resolves in 10 to 14 days. Cultures of microorganisms are negative, and histologically, there is superficial neutrophilic folliculitis with admixture of lymphocytes. Actinic folliculitis is described in young to middle-aged adults of both sexes. Clinical features. It is characterized by monomorphic follicular papules and pustules over the face, neck, upper arm, shoulder, upper chest, following few hours of sun exposure. Symptoms are the burning sensation and pruritus at the onset, which resolves in 10 days. The condition recurs annually over many years and usually worse at the beginning of summer. Differential diagnosis is polymorphic light eruption. This is a monomorphic condition. In polymorphic light lesion, there is polymorphic lesions, miliaria, then papulopustular rosacea. You also find other findings of rosacea like telangiectasias and swelling. Then photoaggravated acne vulgaris, you will find comedones in acne vulgaris. There are no comedones in actinic folliculitis. Follicular provocation test is performed to support the diagnosis. Management. Photoprotection with behavioral modification like hats, clothings, and high factor sunscreen is beneficial. Standard acne therapy is ineffective, but severe cases may respond to isotretinoin. UVB phototherapy desensitization may be employed. The next disease we are going to consider is a disseminated and recurrent infundibulofolliculitis. It's a dermatosis affecting principally chest, shoulder, and upper arms of young black men, characterized by disseminated low-grade spongiotic dermatitis involving the infundibular portion of multiple adjacent hair follicles. It is again manifested in a form of monomorphic pruritic papules, begin in childhood and adult life. Histologically, the inflammatory changes are confined to the infundibular portion of the follicles with spongiosis and mixed infiltrate. No particular infective organism is identified. Clinical features. It is characterized by widespread eruption of a small monomorphic follicular papule on trunk and limbs, sparing the flexures. Occasionally, pustules develop. It is often but not always, itch is often but not always present and intend to persist and may relapse periodically. Management. It is generally poorly responsive to treatment that include topical corticosteroid. Soral and photochemotherapy and isotretinoin have both been reported to be helpful. It is really difficult to differentiate this condition with Pitrasosporum folliculitis because it is also seen on the trunk and is also associated with itching. Only the culture studies will help be able to make a definitive diagnosis. Then we have come to a very important condition that is eosinophilic pustular folliculitis. It's an uncommon cutaneous reaction which is characterized by infiltration of pilosebaceous follicles, not by neutrophils or lymphocytes, but by eosinophils. And this eosinophilic pustular folliculitis is of three types. The adult onset, which is also known as the Ufuji disease. The lesions are predominantly facial and reported mainly from Japan. Then the other condition is an immunosuppression-associated eosinophilic pustular folliculitis, which is strongly associated with HIV but is also seen with other immunosuppressive agents. And this is particularly extrafacial. Then the third condition is infantile eosinophilic pustular folliculitis, which seems to have little in common with adult form. The condition is 5 times more common among men as compared to women. There is a large number of hypotheses, which includes hypersensitivity reaction to Malassezia species, to Demodex, or sebaceous gland-derived lipids. Various chemotactic factors are detected in the fluid of pustules, and there are several reports of the condition developing during pregnancy. However, there is no genetic predisposition. Pathology. The follicular inflammation is characterized by heavy infiltration of the outer root sheath and sebaceous glands by eosinophils and scattered mononuclear cells. In immunosuppression-associated eosinophilic pustular folliculitis, the inflammation seems to be more diffuse. There is mild to moderate peripheral blood eosinophilia in 35% of the patients with classical type and 50% of the patients with HIV-associated eosinophilic pustular folliculitis, which usually occur when CD4 count is less than 200 cells per ml. Now, the first subtype, that is the classical or adult type of eosinophilic pustular folliculitis. It's a chronic relapsing disease with crops of sterile follicular papules and pustules coalescing into inflammatory annular plaques with peripheral expansion and central clearing, mimicking Actinic fasciae. It takes 7 to 10 days for inflammation to subside before the cycle repeats itself. Face is the commonest site. Pustular inflammation of palm and soles may also be seen. And if occurs, then it causes confusion with palmoplantar pustulosis. This is how the adult onset eosinophilic pustular folliculitis would manifest. So the skin biopsy has to be performed to diagnose the condition. Otherwise, you will be confused with tinea fasciae. Trunk, upper arm, leg, and scalp is occasionally affected. The inflammatory plaques may reach 3 to 5 centimeters in diameter before subsiding to leave slight pigmentation. Lake of pus and erosion is sometimes seen, itch is frequent, and it may be severe. Patients are systemically well. The overall course is chronic, with new crop of lesions repeatedly appearing in the affected areas. The second condition we are going to discuss under this heading is immunosuppression-associated eosinophilic pustular folliculitis. This condition is predominantly seen with AIDS infection, HIV and AIDS. It is not restricted to Japanese, which are the commonly involved races in adult onset eosinophilic pustular folliculitis. And pruritus in this condition is more intense. Pustular element is often not as prominent, and clustering into plaque is not a characteristic feature of immunosuppression-associated disease. Facial skin is less commonly involved. The clinical signs may be subtle, and sometimes just scattered follicular papules or excoriation are seen. You can see in these pictures there are multiple follicular papules, but they are not arranged in annular fashion. There's no crustic, no necrosis. This is quite an itchy condition. Paradoxically, eosinophilic pustular folliculitis may first develop after the CD4 counts start to rise with introduction of highly active antiretroviral therapy, in which case it is accompanied by immune reconstitution inflammatory syndrome, which is also known as IRIS. So this condition, the adult onset or immunosuppression-associated eosinophilic folliculitis responds to systemic corticosteroids or potent topical steroids. Topical pimecrolimus or tacrolimus is also advocated. Dapsone is effective in some cases and may be the drug of first choice, the oral dapsone. Oral NSAIDs are widely used in classical form. A proposed mechanism of action is that it interferes with prostaglandin D2 that induces chemotaxis on the surface of eosinophil. So by inhibiting prostaglandin D2, it would inhibit the migration of eosinophils. Other reported therapeutic options include minocycline, isotretinoin, itraconazole, cetirizine, metronidazole, and colchicine. UVB therapy was helpful in 6 HIV-associated cases, although maintenance treatment was required. So that if we go through the treatment ladder, the first line treatment is potent topical steroids, potent picrolimus and tacrolimus, pimercolimus and tacrolimus, indomethacin, narrowband UVB. And in second line, we can use oral corticosteroids, oral antimicrobial like minocycline, itraconazole, cetirizine, or oral isotretinoin. The third subcondition is infantile eosinophilic pustular folliculitis. It's an inflammatory pustular disorder of infants associated with cutaneous and peripheral blood eosinophilia. The condition is characterized by recurrent outbreaks of non-infective pustules containing eosinophils on the scalp of the infant. Two-thirds of cases, other body areas are also involved. Majority of cases, condition commences before the age of 6 months and remit spontaneously by 3 years. Cause is unknown, bacteriology is negative. In a substantial number of cases, there is no follicular involvement. Average age of presentation is 6 months, more common in men, in boys as compared to girls with a ratio of 4:1. It is associated with HIV and also associated with hyper IgE syndrome and atopic eczema. Condition is characterized by recurrent crops of itchy sterile pustules, which recur over several months or years. The sterile pustules develop on the scalp predominantly, but the lesions may occur in other side of the face. Patient can also develop axillary and inguinal lymphadenopathy. Pustular lesions resolve spontaneously without scarring. Investigation is done by doing a Zank smear, culture of bacteria and fungi, HIV test, and IgE test. Because the condition is self-limiting, treatment is usually not indicated. However, with particularly recalcitrant or extensive disease, oral dapsone may be used. So the treatment ladder would include reassurance and topical steroid first, antihistamine and topical tacrolimus second, and third line dapsone. The second last condition I'm going to discuss today is the heterotopic sebaceous glands, also known as the Fordyce spots. The Fordyce spots are the heterotopic sebaceous glands, which are not associated with hair follicles, and these glands are located on the mucosal surfaces of glabrous skin of lips, oral mucosae, and genitalia. These are commonly asymptomatic and is mainly a cosmetic concern, but the readily visible skin and mucosal lesions attract attention. It should be considered as a spectrum of normality. Vulval Fordyce spots are common in women, with reported rate as high as 75 to 95% of cases. Fordyce spot or penile and scrotal skin is an incidental finding. So the Fordyce spot manifests as multiple, smooth, creamy white to yellow, well-demarcated, small pinpoint papules, which may coalesce into irregular plaques. Size is 1 to 2 millimeter or larger, and it is slightly or moderately elevated above the skin on the mucosal surfaces. Develop most commonly on the vermilion of upper lip and the buccal mucosa or labia minora. There are clinical variants. It may be located on the coronal sulcus, either sides of the frenulum, and in this side it is referred to as glands of Tyson. Such are considered as normal structure and need no treatment. Sebaceous glands are found within the tubercle of Montgomery on the areola of the female breast. First line treatment is the reassurance. I think this should be the only line of treatment. The local destruction with superficial cautery or electrodesiccation, topical trichloroacetic acid, or carbon dioxide laser evaporation. All of these procedures can lead to scarring. And one side effect of this may be disturbance of the lip margin. So it is better not to attempt these aggressive modalities for a benign condition like a Fordyce spot. However, in case of extensive lesion, a short or long course of isotretinoin may be tried. The last condition I'm going to discuss today is the sebaceous gland hyperplasia. It presents as scattered, clinically obvious, flesh-colored or yellowish, papules on the face mainly resulting from hypertrophy of sebocytes within the sebaceous glands. It is seen mainly in adults above 50 years, 40 to 50 years. Immunosuppression in transplant recipients may predispose to sebaceous hyperplasia. It is of insidious onset. Patients presents as scattered, asymptomatic, flesh-colored to yellow-pink umbilicated papules, measuring 1 to 3 millimeter in diameter. They are seen especially on the forehead, temple, and cheek, but may occur on upper trunk. The main clinical significance is that it can be mistaken for other disorders presenting as facial papules like BCC. If there is a diagnostic doubt, then biopsy should be taken. First line management is cosmetic camouflage, while second line management include a gentle cautery, cryotherapy or TCA, pulse dye laser of 1450 diameter diode laser or CO2 ablative laser may also be used as a treatment. Third line treatment include oral isotretinoin, which is of considerable benefit. Cyproterone acetate in combination with oral contraceptives is used with benefit to induce regression of sebaceous hyperplasia in female. Photodynamic therapy with use of aminolevulinic acid is also found to be useful in this condition. So this brings us to the end of this talk. Thank you very much for the patient listening, and I will join you next time with another edition of my talks. So till then, goodbye and have a good day.